Thanks for having me here. And let's talk about some facts with the capsulotomies, as far as making it not too big, not too small. And my thought will be to do the interportal capsulotomy. So what are our goals here? As Al mentioned, we want to visualize everything, be able to access everything, do our adequate decompression, be able to see what we're doing. Is there residual instability? Is there residual pain? These are the things that we have to sort out. And if there's a capsular issue post-op, is that a pain generator in the hip? And so this is a picture, a schematic of the several different types of things that we're talking about with respect to capsular closure. The top right would be the interportal, and this would be a little bit of a T. And then we have our repair here of the interportal, and then our repair of the T, and then our repair of everything, including the T and the interportal. So, are there consequences of treating the capsule? Many studies have shown that the capsule closure is very important in reducing residual post-op instability, post-op pain. Doesn't matter how big it is. Theoretically, the smaller the better, but are we trading visualization if it's too small? My opinion would be that the interportal capsulotomy provides just enough exposure without violating too much of the capsule. So this biomechanical cadaveric study was pretty interesting because it was really kind of eye-opening for me. I think a T-capsulotomy theoretically should increase the visualization area, as we know. And this was 20 hips that were identified in terms of a cadaver, and 10 had interportal and 10 had the T-capsulotomy. Half were T-capsulotomy and half was a full T-capsulotomy. So half a half T and half were a full T out of those 10, 2 centimeters and 4 centimeters. And they took a photograph to measure cross-sectional area, and they found that the half T was equivalent to the 6 and 8 centimeter interportal capsulotomy. And the full T was superior when compared to the 6 and 8 centimeter interportal capsulotomy in terms of the visualization. So the conclusions of the study seem sound, but does this full T capsulotomy affect the post-op capsule integrity? And how does it affect the fluid extravasation intraoperatively? Are we causing any iatrogenic microinstability with a large capsulotomy? And do we need that to increase the visualization, or is the interportal capsulotomy enough? So the interportal capsulotomy provides a sweet spot, in my opinion, between the visualization and the hip and violation or changing hip kinematics. And this seems to bear out in our biomechanical data with this cadaveric study that looked at eight cadaver hips with 7 capsular conditions. One was intact, one was with portals, one was with the interportal capsulotomy, one was interportal capsulotomy with repair, one was a T-capsulotomy, one was a T-capsulotomy with partial repair, and then T-capsulotomy with full repair. So they looked at the changes in the AP translation and the internal external rotation, as well as medial lateral translation. The unrepaired interportal capsulotomy showed less kinematic issues than the unrepaired T-capsulotomy, but if completely repaired, there was no difference. So this would confirm logically that the T-capsulotomy is a bigger kinematic insult than the interportal capsulotomy. But if they are repaired, there is no difference. Dr. Philippon's biomechanical study was 10 cadaveric hips, and these were tested for range of motion for the intact capsule versus the multiple capsular conditions, similar to the previous study. And they tested it in different planes of motion. And what they found was that the interportal capsulotomy had significantly less external rotation at 0 compared to the T capsulotomy, as shown here. So interportal less than the T. And also the internal rotation was significantly less at 10 degrees, 60 degrees, and 90 degrees. So at all those ranges of motion, flexion angles. Also, the abduction was significantly less at all those flexion angles as well with the interportal capsulotomy. So, and also adduction here as well. So, do any of these biomechanical studies translate to clinical meaningfulness? So this was a level 2 study that was a prospective randomized trial that compared 150 patients undergoing hip arthroscopy for FAI with either a T capsulotomy without closure, interportal capsulotomy without closure, interportal capsulotomy with closure. So there were three groups. So they assessed the revision rate, the conversion of total hip, modified Harris hip score, and the Haas scores at 2-year follow-up. And they found the revision rate was highest in the T-capsulotomy group, but that was not significant. The total hip rate was highest in the T-capsulotomy group, and the outcome scores were better in the interportal capsulotomy group. So bottom line is, do we really need a full T-capsulotomy to do the necessary work? Why are we creating a bigger capsulotomy if it isn't needed and risk inadequate repair? And why do we want to limit our visualization and continually internal and external rotate the hip to utilize these small windows to get a decompression and the exposure that we need?